Hello everyone, my name is Arun Sebastian. I'm a PhD student at the University of Sydney. Today I'm going to talk on the topic identifying the predominant site of upper airway collapse in obstructive sleep apnea patients using Snore signal. The main aim of the study is to use audio signal as a simple, non-invasive method to find the predominant site of collapse in upper airway during hypopneas. The information regarding the site of collapse could improve OSA treatment by allowing more structure-specific or individualized therapy. In this study, we analyzed the correlation between snoring during hypopneas and the site of collapse. Obstructive sleep apnea, or OSA, is a highly prevalent sleep-related breathing disorder which is characterized by repetitive obstruction in upper airway. The conventional treatment for OSA are continuous positive airway pressure, or CPAP, oral appliance therapy, and surgery. CPAP is considered the first-line therapy, but low patient adherence and acceptance make it less effective in real-world application. Oral appliance provide an alternative treatment for patients who cannot tolerate or refuse CPAP. But the catch is that oral appliances are only effective in some patients, and it is difficult to predict which patients will respond well to the therapy. Even though different treatment modalities are available, the key unresolved issue of OSA treatment is the inability to predict the most appropriate treatment. Studies have demonstrated that determining the site of upper airway closure is an important determinant of treatment outcome. Various studies suggest that identifying patients with tongue-based collapse would assist clinicians in choosing better treatment using oral appliance therapy. Also, the efficacy of surgical treatment for OSA highly depends on accurate information regarding the tonsil obstruction. The gold standard method for identifying the site of collapse is endoscopy, or a pressure catheter, which is passed via nose into upper airway during drug-induced or natural sleep. Unfortunately, this method is not suitable for clinical practice due to its invasive nature and time and expense of the test. Recently, researchers have demonstrated that the shape of nasal pressure waveform can be used to identify the site of airway collapse. But the main disadvantage of this study is that airflow was measured using a sealed mask and a low level of CPAP were used to maintain stable flow limitation. Snoring is one of the hallmark symptoms of OSA, which is caused by the vibration of different tissues in upper airway. Snoring properties vary with shape and physical dimensions of upper airway, and therefore, it may carry information related to the site of collapse. Studies conducted in relation with snore and site of collapse were focused on finding the correlation between various acoustic features of snoring and the site of collapse. The main limitation of these studies were that they used drug-induced sleep endoscopy or pressure catheter along with the snore data collection, and the evaluation was based on analyzing a few snore episodes. Previous studies by us have demonstrated that snore during hypopnea event can be classified into 3 sites of collapse. In this study, our objective was to automatically classify OSA patients into 4 categories: lateral, palate, tongue-based, and multi-level site of collapse based on the predominant site of collapse using snore data. Coming to our database, our subject population includes 58 patients who attended a full night sleep study using PST at Royal North Shore Hospital, Sydney, and received a diagnosis of OSA. The patient's respiratory sound signal were recorded simultaneously with PST data using a microphone which was placed on the ceiling about 1.5 meters above the patient's bed. Audio data was synchronized with the PST recordings. The probable site of airway collapse was determined by an indirect process, by manual analysis of shape of airflow signal during hypopnea events using the reference pattern shown in the first figure. Using the airflow reference pattern, 3 sites of collapse, lateral, palate, and tongue-based, were determined based on the flattening or scooping of airflow contour. The labeling was performed twice with the help of an experienced sleep physician to validate the reliability. The second figure shows an example of airflow shape during a hypopnea event, which indicating a lateral wall collapse and the corresponding audio signal. This resulted in a database consisting of more than 1,800 hypopnea events. In the next phase, we find the predominant site of collapse for each patient. We define predominant site as if more than 60% of total event were of same type, then the predominant site of collapse for a patient was set to this type. Otherwise, it was set to multi-level obstruction. We extracted 50 identical features from each hypopnea event, consisting of various time and spectral features considering their potential link to upper airway physiology. Extraction was done using a frame size of 10 seconds and a frame step of 5 seconds, then taking the average across one hypopnea event. The time domain features consist of energy, entropy, and zero crossing rate. And the frequency domain features consist of 3: Forman frequency, Mel frequency substance coefficient and its first derivative, spectral entropy, flux, centroids, spectral chroma features, fundamental and harmonic frequencies. We developed a multi-class linear discriminant analysis classifier for categorizing the site of collapse based on the Snore signal, and the features for the model were identified using a nested cross-validation technique. For the performance evaluation, the patient's data is divided into two subsets. The first one is learning set, which consists of 45 patient data to build the model, and the next one is hidden set, consisting of 13 data, which is used for testing the performance of the model. Performance was evaluated by comparing the automatic and manually labeled data based on the predominant site of collapse for each patient and then calculating the accuracy. The first experiment, we evaluated the performance of learning set, that is 45 patients data, using the best combination of features for each patient with a nested cross-validation technique. This model was trained using a data from 44 patients and tested on the remaining one patient, and this process is iterated across all the patients. The result shows that our automatic system can achieve an overall accuracy of 65% for determining the predominant site of collapse for all the site of collapse classes, and an accuracy of 80% for classifying tongue and non-tongue related collapse. In the next phase, we evaluated the performance of the model using a hidden set data to provide a prospective evaluation of the system. The model was trained using the training set with most commonly selected features from the nested cross-validation from the previous step. The result shows that this model can achieve an overall accuracy of 69% for determining the predominant site of collapse for all the classes, and an accuracy of 84% for classifying tongue and non-tongue related collapse. The most selected features were consist of 3 MFCC coefficient, 2 first derivative of MFCC coefficient, fundamental frequency, and 1 chroma feature vector. In conclusion, we introduced a non-contact, inexpensive technology using audio recording during normal sleep to indirectly identify the site of collapse. The result indicate that the acoustic properties of hypopnea-related snore sound varies in association with the site of collapse, and therefore it can potentially be used as an auxiliary method to identify the predominant site of collapse in OSA patients. A limitation of our study was that we have not used a gold standard method to find the site of collapse. An indirect method of labeling may introduce some labeling errors. Another limitation of our study was that our method currently requires hypopnea event scoring, and the snores were detected without considering the body position, which may influence the signal quality and audio frequency of the recording. The future work related to this study will be predicting the treatment outcome using the snore data and validate with longitudinal outcome data. Another area of research is the development of screening tool that uses audio data only to predict apnea events and the site of collapse. And thank you all for your attention. If you have any questions, please send an email to arun.sebastian@sydney.edu.au. Thank you.